Our next study is diabetes and periodontal health.
Can you all hear me? All right, my name is Eric, and our group looked at the effects of non-surgical periodontal therapy and how it can affect the HbA1c levels in type 2 diabetic patients who are also non-smokers. Next slide, please. So first I'm going to talk about how periodontal conditions are diagnosed and how we record our data there. So we all know that when we do our comp exam, we measure our probing depths, and then we also look to see if there's any recession present. And our probing depths go from the base of the gingival sulcus to the top of the free gingival margin. And if there is any recession, that is measured from the top of the free gingival margin to the CEJ. If there is not the CEJ present and the gingiva is over it, then we roughly can subtract 1.7 to 2 millimeters from that to get our clinical attachment loss, which is made up of our probing depths and any recession present. We know that we use our clinical attachment loss to make our periodontal diagnosis, and then we use our probing depths to determine the types and the amount of SRP needed for the patient. Next slide, please. Now I'm going to talk about HbA1c and what it does for us. So we all have blood in our bodies, and we all have sugar in our bloodstream, and we have a protein in our red blood cells called hemoglobin, and the sugar binds to hemoglobin, and we use an A1C test to measure the percentage of sugar bound to our red blood cells. Normally, our A1C is below 5.7%. In pre-diabetics, it's between 5.7 and 6.4%, and for diabetics, it's above 6.5. And A1C is the most common diagnostic measurement for diagnosing diabetes, and they need a reading above 6.5 on 2 separate occasions. Next slide, please. So our group, we started off by doing a literature review to see what studies have been done in the past and if we could learn anything from them. This was just one of them that we found, and where they did a study and found that HbA1c levels are positively associated with high probing pocket depths in patients with non-insulin dependent diabetes. Next slide, please. So our research question was, does non-surgical periodontal therapy help lower HbA1c levels in those diagnosed with type 2 diabetes who are also non-smokers? Next slide, please. So the aim and introduction of our study was to better understand the relationship between periodontal disease and type 2 diabetes in non-smokers, and through our study, be able to better educate our patients on improving their periodontal health and also their diabetic glycemic control through improving their oral health and their periodontal condition. Next slide, please. So our group encountered many limitations like most of the other groups. Most significantly was that our IRB form was not approved very quickly, which really limited our time to recruit patients and to perform our study. In general, HbA1c values are measured every 3 months, and you know how it is with our patients at the clinic. It takes a while to get through our comp exams and all our SRP treatments and to actually get our patients to show up sometimes. So therefore, we're kind of using this as a pilot study to complete the research in the future. So like I said, we had our limited time to recruit our patients, and then also time for our patients to bring in their HbA1c values. I know personally I have patients that I tell them they need to go to their doctor and get their HbA1c values, and they don't listen to me. So, and also, as many of you know, a lot of our patients at the clinic smoke, and so it was also challenging to find type 2 diabetic patients who were also non-smokers. Next slide, please. So like I said, we started off by doing a literature review of existing studies, and our conclusions through that were that generally the consensus was that non-surgical periodontal therapy, scaling and root planing helped decrease HbA1c levels in type 2 diabetic patients who do not smoke. So going forward, we will get our patients to sign consent forms for participating in the research study. We will have them go to their doctor and have a HbA1c value measured before the start of scaling and root planing. We will complete all of the necessary treatments there, and then we will reevaluate them in 4 to 8 weeks. And after that, we will have them go back to their physician and have their HbA1c value measured in 3 months. And then we will record the changes and run some statistical analysis to see what we have. Next slide, please. So with that, I would like to thank Dr. Marquez for leading this research group. And I would also like to thank Dr. Omar for her guidance with helping us through this challenging situation. Thank you. Are there any questions? Dr. Salama?
Thank you. I just wonder, did you think about using, some physicians now, they do their measurement for H1C in the office. So they take just a little blood and they do it, and in 5 minutes the results will come. Maybe in the future, if you use this and if it is allowed in the school, I'm not sure about that, but it can be done and you can get faster results, okay? Like if you do the pre, then you do the surgery, then maybe you will do a follow-up. When they come for follow-up, you do the second one. It's just a suggestion because I know it is difficult to get things done outside and 3 months waiting, and the patients may not get the response you want in the right time. Thank you. You don't have to answer.
So you said that that's an in-office HbA1c measuring device? Okay. We will take that into account.
What's the connection between smoking and A1C levels? Why was it important to have non-smokers in your study and not anybody?
That's a great question. I think smoking can be a contributing factor to type 2 diabetes and also to periodontal disease. So we just wanted to make that an exclusion criteria to mainly focus on how effective the scaling and root planing can be in reducing that glycemic control. That's my understanding. Any other questions?